So today we will focus on cardiovascular autonomic dysfunction in movement disorder. Because of time constraint, because autonomic dysfunction in movement disorder is really a huge topic, a huge word. So we decided today to focus just on the cardiovascular aspect, and maybe in the future we will consider to have further webinars on other aspects like the genitourinary or the gastrointestinal autonomic dysfunction in movement disorder. So our learning objective for today will be to help you to recognize symptoms of cardiovascular autonomic dysfunction, to learn how to perform the proper diagnostic workout for cardiovascular autonomic dysfunction, and how to organize management plan for these conditions. So we will start looking at signs and symptoms of cardiovascular autonomic dysfunction, and then we will focus on the workout, and finally on treatment. These are my disclosures. So the involvement of the autonomic nervous system in Parkinson's disease has been recognized since the first description by James Parkinson. Especially in his first description, he described very well the gastrointestinal involvement, the constipation, but also the postural instability that may be related also to orthostatic hypotension, even if he do not directly measure this aspect. On the other side, from the autonomic nervous system world, in the Bible of the autonomic nervous system, which is the book by Christopher Matthias, Autonomic Failure, we see that in its classification of autonomic nervous system disease, we see that among the primary forms and the chronic forms are listed all the synucleinopathies, not just pure autonomic failure and MSA, but also Parkinson's disease. The problem is that since the autonomic nervous system with its two branches, the sympathetic and the parasympathetic, innervates all the organs and tissue of the body, the possible manifestation of an autonomic dysfunction may be extremely heterogeneous and usually present with a specific symptoms and usually affect domains that are not typically addressed by neurologists, like, again, the gastrointestinal function, the genitourinary function. So, and the other problem when we have to address this aspect is that the severity and the pattern of involvement may vary widely depending on the underlying process, on the lesion, on the site that has been damaged, and depending on the disease stage. So presentation may vary widely. But what are we talking about? So you all know that when we lie supine, blood volumes and pressure are distributed evenly throughout the body. But every time we stand up, immediately after we stand up, we see a translocation of about 500–700 ml of blood to the lower limb because of gravity. And this causes a fall in blood pressure above the heart level. In healthy subjects, compensatory mechanisms take place immediately after and are able to redistribute the blood volume and restore the blood pressure. But this is not always the case. In some subjects, this may not happen, and the blood pressure drop and hypoperfusion may occur. And this is what happens in this gentleman. This is a 72-year-old gentleman who was referred to our clinic because of falls. You see, this is how we perform the T table testing. This is a all the signals we get the EEG, the ECG, the blood pressure, and the tachogram, and the breathing. And you can see here that as soon as he has been tilted up, his blood pressure starts to fall. But he's doing well. The technician just asked him, how do you feel? And he said, I'm feeling well. I don't feel anything. But look at his blood pressure. You see here, he was 140/77 supine. After 3 minutes of tilt, his blood pressure dropped to 77/48 with no compensatory increase in heart rate. So this is what we define orthostatic hypotension, that according to the definition is a sustained reduction of systolic blood pressure of at least 20 millimeters of mercury or diastolic blood pressure of at least 10 millimeters of mercury within 3 minutes of standing or head-up tilt test. We do not have just the classical form. We may be aware that there be some other forms like the initial orthostatic hypotension that is just a transient fall in blood pressure happening within 15 minutes of standing and fulfilling the criteria of a drop of at least 40 millimeters of systolic and 20 millimeters of diastolic, associated with symptoms of cerebral hypoperfusion. And sometimes instead we have a delayed orthostatic hypotension, which is not clearly evident at the 3rd minute, but may manifest after the 3rd minute. And we believe that this condition may represent a prodromal form of classical orthostatic hypotension. So what are the symptoms related to orthostatic hypotension? Patients may report feeling dizzy, having visual disturbances, also some kind of cognitive slowing, and if the blood pressure is big enough, they can end up in syncope. Most of them also report some muscular hypoperfusion symptoms. Very typical is what we call the coat hanger pain. That is a pain affecting the neck and the shoulders, which happen every time the subject stand up and ameliorate when the patient is laying down. Patient may also report some symptoms mimicking an angina, and it's not unfrequent that some of our patients with severe orthostatic hypotension underwent coronography, but their coronary arteries are perfectly fine. The problem is the fall in blood pressure that is so severe, causing cardiac hypoperfusion. And they may also present some other specific feature like fatigue, dyspnea, and oliguria during the day due to kidney hypoperfusion. All these symptoms obviously appear exclusively upon standing and abate when sitting or lying down. And now, but we know the patient tend not to report these symptoms, so these symptoms should be actively investigated by the clinician. We have to ask a specific question regarding this aspect, especially in movement disorder clinic. And please also consider that frequently orthostatic hypotension can run asymptomatic. The reason is that the symptoms occur especially when the blood pressure falls below a threshold that is 75 millimeters of mercury of mean blood pressure. If the patient has a severe orthostatic hypotension, but do not go below this threshold, most of the time do not report symptoms. So the other take-home message is that we cannot just rely on patient symptoms. Orthostatic hypotension is a clinical sign and should be searched actively. It's enough to measure blood pressure supine and standing with a standard blood pressure cuff, and you will get very important information for your clinic. So my first question for you is, do you believe that orthostatic hypotension is a rare condition or is a relatively frequent condition? Consider that orthostatic hypotension can be found in over 20% of patients over 65 years of age and is the cause of syncope in about in 25% of patients coming to the emergency department, and it approximately affects 30% of PD patients. Even if there are some big discrepancy regarding the frequency of orthostatic hypotension in Parkinson's disease. There are some, according to some study, goes from 5 to 50% of patients. For sure, in alpha-synucleinopathy, there is a continuum, and so orthostatic hypotension tend to be much more frequent in MSA compared to Parkinson's disease. In MSA tend to be much more aggressive, much more symptomatic, and early in the disease course compared to Parkinson's disease, while dementia with Lewy body is about in the middle between these two conditions. We, as a Bologna group, believe that 50% of incidence of orthostatic hypotension in PD is probably an overestimate. We conducted a study 3 years ago in which we enrolled 105 PD patients within 3 years from motor onset. 80% of them were drug naive, and we were able to demonstrate that neurogenic orthostatic hypotension was present only in a small proportion, 4% of cases. But after 16 months, this proportion nearly doubled. It was like 8% of patients having neurogenic orthostatic hypotension. And this should be reminded, because if you find neurogenic orthostatic hypotension in a patient with Parkinsonian feature, this in early stages, this is definitely still a red flag for atypical Parkinsonian syndrome. And this was also confirmed by a recent study by Italo Biagioni, which demonstrated, as we did in the past, that there is a progression. So orthostatic hypotension probably is not so common in the initial stages, but frequently in initial stages we can see some features of autonomic dysfunction if we perform standardized cardiovascular autonomic testing. So how shall we address orthostatic hypotension? So finding that a patient has orthostatic hypotension is just the beginning. The first question we should ask is, has he got any identifiable cause for that? First of all, is he taking any drugs that may cause orthostatic hypotension? Is he hypovolemic? Has he got a cardiac condition that may cause orthostatic hypotension, or venous pooling or deconditioning? If the answer is yes, for sure this is not a neurogenic orthostatic hypotension, and is an easily treatable condition if we treat the underlying causes. So as we said, the main causing aggravating factor for orthostatic hypotension is definitely drugs, and we think not only of antihypertensive, but also think of drugs that the patient may not report to you because were prescribed by the urologist. So alpha-lytics are can cause orthostatic hypotension for sure, but also the medication we use to treat Parkinson disease, levodopa and dopaminergic agents. For instance, do not take for granted that if a patient has a neurological condition like PD, he will definitely have neurogenic orthostatic hypotension. Here you see the tilt test. So this is the blood pressure profile supine, and this is during tilt, and this is back supine in a patient with Parkinson disease. So he definitely has orthostatic hypotension. But is this neurogenic? After the patient in the performing this test reported that he made a mistake. He took levodopa before coming to the lab. So we decided to repeat the test and look at how different is the blood pressure profile. He doesn't have a neurogenic orthostatic hypotension. He had a drug-induced orthostatic hypotension that was related to levodopa. So, but it's not just if we want to be 100% sure that the origin of neurogenic orthostatic hypotension is neurogenic, we should search for other markers of cardiovascular autonomic failure. What are these markers? There may be many. One direct marker is the assessment of plasma norepinephrine. As you know, plasma norepinephrine should be around 100, 120 supine and should double during tilt. If you find low blood pressure, low norepinephrine values during tilt, if there is no release in norepinephrine, this is due to a neurogenic form. This is neurogenic orthostatic hypotension. The other marker we look at is the Valsalva maneuver. I do not have time to get into detail, but this simple maneuver can really provide us huge amount of information. Here you see the blood pressure profile of a control subject, and you see especially that at the end of the maneuver we have this beautiful rise in blood pressure, what is called overshoot. In a patient with orthostatic hypotension, due to a baroreflex dysfunction, there is no no compensatory rise in blood pressure during the maneuver, and there is no overshoot at the end of the maneuver. And this is indicative of neurogenic orthostatic hypotension. Another aspect you can look at is the changes in heart rate in patient with orthostatic hypotension. So if the baroreflex is functioning, we do expect that if there is a blood pressure fall, you will have a compensatory rise in heart rate. If this do not happen, so probably there is a neurogenic mechanism behind. And it was suggested that this index that simply means that if a subject has a fall in a systolic blood pressure of at least 20 millimeters of mercury and do not have a rise in heart rate of at least 10 beats per minute, he or she will probably have a neurogenic orthostatic hypotension. And this has been demonstrated by the New York group, our group, and also Alessandra Fanciulli group in Innsbruck, also in clinic. So this is a useful tool to be checked also in your clinic with a simple blood pressure cuff. Another aspect you can do in clinic is looking for the 24 hours blood pressure monitoring. And you can see here how different is the profile in a healthy control, in which blood pressure basically remain more or less within limits during the day and then tend to decrease during the night. And here you see the blood pressure profile of a patient with orthostatic hypotension. And you can see that there is higher variability in these blood pressure values. There is frequently a drop in blood pressure after meals. This is a postprandial orthostatic hypotension. And there is no dipping of blood pressure during the night. And there might be a reverse dipping, a rising in blood pressure value during the night. And this is also indicative of suggestive of a neurogenic orthostatic hypotension. And another thing you can looking at the 24 hours BP monitoring is looking at the standard deviation of the systolic blood pressure. If this is above 16 millimeters of mercury, this is a possible clue to neurogenic orthostatic hypotension. But as you know, the pathophysiology underlying orthostatic hypotension is not exactly the same in MSA compared to PD. In MSA, we know that there is a central network dysfunction causing orthostatic hypotension. Instead, in PAF, pure autonomic failure, is just a peripheral dysfunction, and in PD is something in between these two conditions. So this is also reflected looking at heart rate. So generally speaking, patients with MSA tend to have, at least in the initial forms, still a compensatory rise in heart rate during when they have orthostatic hypotension, while peripheral forms have a rather fixed heart rate as the one we saw before. But in the other aspect is that if we want to have more clues, trying to differentiate if the patient has a central, whether a peripheral form, we do need to perform the not just simply the tilt of the Valsalva, but is recommended to perform the all the classical cardiovascular reflex test battery, which is a standardized assessment, and which includes not only the tilt, the Valsalva, but also the deep breathing, the cold face, the isometric exercise test, and each of these tests addressed a specific aspect of the autonomic control of the cardiovascular system. And we also published this paper showing that having the full battery may help to differentiate patient with MSAP from PD even in an early stage. And this is also so it's not just performing the whole battery of the cardiovascular reflex test, but as you know, also the changes in noradrenaline may help to differentiate peripheral forms from central forms. In a peripheral form, catecholamines tend to be low supine with no increase during tilt. while in MSA, they tend to be normal supine with no increase during tilt. And other clues can be derived also from sweat test and MIBG. The other thing that you should consider is just there is not just neurogenic orthostatic hypotension, but people with neurogenic orthostatic hypotension frequently have also supine hypertension, which is defined as the occurrence of systolic blood pressure about 140 and diastolic blood pressure about 90 millimeters of mercury when measured after at least 5 minutes of rest in the supine position, and can be divided in mild form if they fall between this range, moderate form, or even severe forms. And this is something that needs to be addressed for many reasons, because of course, if the patient has orthostatic hypotension, but also has supine hypertension, this will limit our use of pressor agents. Supine hypertension during the night causes severe natriuresis. This patient may urinate above 2 liters of urine every night and will be very dehydrated in the morning. And supine hypertension may also cause chronic organ damage. So not only kidney dysfunction, but also white matter lesion. And so why it is extremely important to address orthostatic hypotension? For many reasons. First of all, because orthostatic hypotension really affects very severely the quality of life of our patient. Patient with severe orthostatic hypotension cannot have a shower, cannot shave themselves standing up, cannot can walk just for a few meters. I have people with orthostatic hypotension have a very much higher probability of falls and fractures, but also other kind of mobility. There is a relation between orthostatic hypotension and heart failure. And a new aspect where we're starting to pay attention to is that probably orthostatic hypotension may also have some cognitive may be related to some cognitive decline. So it's not just a problem of quality of life, of morbidity, but it is also important to objectivize the presence or absence of orthostatic hypotension, because this has also prognostic value. We know that the occurrence of orthostatic hypotension is a negative factor, while, for instance, in patients with MSA, if the autonomic dysfunction appear later in the disease, this is a good as a good prognosis. So, regarding treatment, first of all, according to you, which are the aim of the treatment? Shall we aim at reducing the frequency of orthostatic hypotension symptoms, or to normalize blood pressure value? Absolutely correct. So there is no point in trying to normalize the blood pressure values, because these patients will have extremely variable blood pressure values. The baroreflex is no more functioning. The baroreflex is no more able to maintain the blood pressure within normal limits. And we do not have any agent trying to ameliorate this aspect. The only thing we can do is to aim at reducing the frequency and the intensity of symptoms. And how can we do this? Simply rising their blood pressure values, in order that even if every time they will stand up every time they will have food, every time they will have a hot shower, their blood pressure will fall anyway, but it won't fall to a level causing symptoms. So we advised a four-step approach for treating orthostatic hypotension. The first thing to do is medication review, because as we said before, the first cause of orthostatic hypotension are drugs. So we have to remove medications that can cause or worsen orthostatic hypotension, alpha-lytic, dopaminergic, also antidepressant, diuretics, nitrates, phosphodiesterase inhibitors, vasodilator, etc. The second point is not a trivial point, is non-pharmacologic measurement. This is very important. You take the time to discuss this aspect with your patient. And it consists in advising to increase fluid, increase salt intakes, use compression stockings or abdominal binders, and have some exercise. So as I said, this aspect may look trivial, but these are proved effective. For instance, just drinking a couple of glass of water has been proved to increase blood pressure by 15 millimeters of mercury for about 30 minutes. This physical countermaneuver can help to avoid the fall in blood pressure caused by orthostatic hypotension, and may help people not to reduce the abrupt fall in blood pressure and to fall down. And another very important aspect is to sleep, to advise the patient to sleep in a position that is nearly tilted. They have to elevate the head of the bed, putting some bricks or a piece of wood of about 25 centimeters, having this maneuver will first of all avoid supine hypertension, will reduce nocturnal poliuresis, and will train the cardiovascular system to standing. So is a simple maneuver, but with lots of benefits. And then we have pharmacological measurement. Some of these pharmacological measurements are food and drug approved medication. The most commonly used, of course, is midodrine, that, as you know, is an alpha adrenergic receptor agonist. We tend to advise the tablet because we need high dosage for this medication to work. In our experience, we need about 2.5 from 2.5 to 7.5 milligram 3 times in a day to get an effect on orthostatic hypotension. Of course, you may use caution in patients with heart failure or chronic renal failure. Another important medication is droxidopa. Droxidopa is currently not available in Europe, but can be imported from the US or Japan. The good point of this medication is that this is a prodrug, so it's not immediately effective, but it becomes effective when it's converted into norepinephrine. So it has a reduced incidence of supine hypertension. Should be taken 3 times in a day. We use the tablets that are 200 milligrams, and we advise from 1 to 3 tablets 3 times in a day. And the side effects and precaution are the same of midodrine, basically. And then we use off-label medication. The most commonly used is fludrocortisone, which is a mineral corticoid whose its function is to expand the intravascular blood volume. We use 1 tablet or maximum 2 once in a day. To prove effective, you will see that patient after about 2 to 3 weeks after starting fludrocortisone will report you having gained at least 1 kilo of weight. And this is the effect of fluid retention. And this is basically what we want. So do not be scared of this. Obviously, but you will have to monitor for supine hypertension and hypokalemia and lower limb edema. Another medication that is an off-label medication we may use as an add-on medication is pyridostigmine. And we tend to use from half to 1 tablet 2 to 3 times in a day. This may potentiate neurotransmission at the peripheral cholinergic synapses, amplifying the effect of the sympathetic nerve activity. And in severe cases, we also consider the combination of all these treatment, because as we said, they act at different sites, so we can consider to combine their effect. In our experience, we tend to combine the use of midodrine and fludrocortisone, or droxidopa and fludrocortisone, and maybe on top of this we may use a pyridostigmine. There are new treatment on the way, probably. There is currently a clinical trial ongoing on ampreloxetine, which has another mechanism of action, because this is a norepinephrine reuptake inhibitors and may be helpful, especially in neurogenic orthostatic hypotension in MSA. And a few years ago, there was also this report of an implanted system for orthostatic hypotension, but since then I haven't seen any updates, so I'm not sure this will be suitable in the future. So in a patient which has both neurogenic orthostatic hypotension and supine hypertension, which treatment we should prioritize? Do we prioritize the treatment of supine hypertension or of neurogenic orthostatic hypotension? The point I wanted to make is that in this patient is more dangerous the orthostatic hypotension than the supine hypertension. So we should prioritize the treatment of neurogenic orthostatic hypotension. And we tend to treat supine hypertension only in severe cases. So if their supine blood pressure value is above 180, 105, 110, because in order to treat supine hypertension is this patient is you can use other non-pharmacological maneuvers. So elevate the head of the bed, do not lie down during the day, use meals that are cause postprandial hypotension as to lower their blood pressure. And instead you should consider using pharmacological agents to treat supine hypertension only in very severe cases, and using short-acting hypertensive at bedtime like losartan, captopril, or nitroglycerin patch. So in conclusion, the messages are that autonomic dysfunction cardiovascular autonomic dysfunction are frequent in all synucleinopathies, frequent and present in all synucleinopathies. They may also sometimes predate the onset of the movement disorder. They have prominent and disabling manifestation. They may help us also to differentiate the various synucleinopathies, and they may also carry important prognostic value. And I thank you, and I thank Professor Cortelli, who recently retired, for giving me this opportunity to get into this field. Thank you.
What to do about cases where the blood pressure is high during the day, but they have EPS, episodes of orthostatic hypotension?
Okay. Yes. In my experience, in these cases, it's very important to have a 24-hour blood pressure monitoring, and to ask the patient to do not just perform the assessment, but to keep a diary of that day. Basically, all the time the blood pressure cuff takes the measurement, we ask the patient to write down if they were sitting, standing, or what kind of activity they were doing. We ask them to report the time of meals, the times of medication, because it's true, most people, the majority of people are scared of high blood pressure, and they do not consider the risk instead of having low blood pressure. And so especially the caregivers will, when you start this medication, they will immediately call you up saying, "Oh, doctor, I found that the blood pressure went up to 160, 90, what shall I do?" I mean, you have to explain them that the problem is not high blood pressure, is low blood pressure, that is they can lower blood pressure very easily, just making the patient stand up, have a rise the stairs, or having a small snack, and just to prove themselves, asking them to take also blood pressure measurement at home, showing that when the patient is standing, the blood pressure is not high at all, and that our aim is that we need the patient to stand up, to move, to treat also his movement disorder.
Thank you. There's another question in the Q&A. At older ages, how common is neurogenic orthostatic hypotension with essential hypertension?
Okay, so here I think we have to differentiate between neurogenic orthostatic hypotension and orthostatic hypotension. As I said, general orthostatic hypotension is very common in the elderly, and it increases definitely with age, and it increases in patients with polypharmacological treatment. Instead, I would say that the neurogenic orthostatic hypotension depends on the underlying condition. So it's not is possible, but not so common in PD. Is very common in MSA and is always present in a PAF, for instance.
Now, another question in the chat. Would you suggest routine 24 hours blood pressure monitoring in PL and other synucleinopathy patients? And if so, at what stage?
Okay. Well, I wouldn't do it by default, but if a patient starts complaining of falls, start complaining of postural instability, start complaining of other orthostatic intolerance symptoms, I would then ask him to, first of all, take a blood pressure diary at home, so measuring just blood pressure, supine and standing, 3-4 times in a week. And if this fulfills the criteria for orthostatic hypotension, then I will ask to perform the 24-hour blood pressure monitoring.